Now, I'm going to say a bit about the major research methods. Each of these has its place. Retrospective studies, cross-sectional studies, short longitudinal studies, and random allocation studies have all been used in a growing literature now. In fact, Strober's latest book on the Handbook of Bereavement Research is about that thick. Each of these methods has its value and its limitations. For instance, retrospective studies are quite useful for helping us to look at the effects of bereavement on physical and mental health. They have the disadvantage, of course, of errors of recall. People don't necessarily remember things the way they actually happened. In a way, I suppose you could say every time we take a psychiatric history, that is a retrospective study, because people are telling us their story as they see it, with all its errors and biases. Systematic history taking focused on particular issues following a bereavement can give very valuable information. And when we find a significant association between a bereavement and an illness onset, that may also enable us to begin to explore the intervening variables that explain a particular illness. For instance, Lindemann carried out a very important study following up in 1945. There was a fire in a nightclub in Boston, Massachusetts. And he followed up bereaved families and produced a paper called the Symptomatology and Management of Acute Grief, which was one of the most important and seminal papers in the field. That was triggered by his interest in ulcerative colitis. He did a study of the precipitating factors in patients with ulcerative colitis, and bereavement kept popping up. So he did a more systematic study showing how his ulcerative colitis, first onset of ulcerative colitis, was commonly the result of a loss of one sort or another. One of my own earliest studies of psychiatric patients was of this kind. This comes from that study. What I did was to go through thousands of case notes of patients admitted to the Bethlehem and Maudsley hospitals, looking for evidence in the histories of the death of a parent or spouse during the course of the 6 months before the onset of their psychiatric disorder. And you'll see here that I was able to compare the incidence in this psychiatric population of these three different kinds of bereavement, father, mother, and spouse, and compare it with the expected number of deaths based on age-matched death registrations. This was a national death registrations. And you'll see how the biggest difference was here in people who'd lost a spouse, where there's obviously death of a spouse playing a much bigger part in these psychiatric illnesses than death of a parent. And this was one of the things that, again, triggered off my interest in bereavement and my decision to look more closely at this whole area. Again, sample of bereaved people, asking them to rate the frequency of marital disagreements, and then comparing this with a measure of outcome. I divided people in this particular study into good, intermediate, and bad outcomes, and as you can see, the people with the largest number of good outcomes had the fewest number of marital disagreements. People with 3 or more marital disagreements were much more likely to have bad outcomes after bereavement. I won't bore you with the details of how we measured outcome and that sort of thing, but it'll give you an idea of the value of this kind of intervention. I should emphasize that it's tempting to focus rather on the results of these studies rather than the methodology. Here I want to focus more on the methodology. Within group comparisons enable us to compare within the sample things like different age groups or gender differences within the sample. For instance, in this study, the men on the left, women on the right, you can see how men were much more likely to say they never cry, they find it hard to show affection, and hard to express grief. So one can immediately begin to get an idea of a different pattern of grieving between people of the different genders. Or you can compare bereaved people with other bereaved people in control groups of one sort or another. Again, here we matched people seeking psychiatric help after bereavement and controls, let's say, people not seeking psychiatric help. And this shows the proportion of unexpected bereavements. And you can see that unexpected bereavements were much commoner in the psychiatric patient seeking help than in the bereaved controls, suggesting that unexpectedness is one of the factors that explains why people seek psychiatric help after bereavement. Short longitudinal studies overcome one of the disadvantages of the cross-sectional study. The cross-sectional studies tell you about what things are like now. What they don't do is to enable you to follow change over time. So the great advantage of the short longitudinal study is to follow things up over time, and that slide, which you've seen before, does exactly that over a period of 10 years. Finally, there's the sort of gold standard of all studies where you're concerned to test the effectiveness of interventions, the random allocation study. This one shows this is a group of high-risk bereaved people who were assigned either to intervention or no intervention. Beverly Raphael is herself an Australian psychiatrist who provided therapy for the intervention group, and the non-intervention group were put on a waiting list. And when she followed them all up a year later, these are the differences in outcome as measured in her study. Highly significant finding, suggesting the value of her intervention. So what can we conclude from these studies? First of all, ethical research in bereaved people is possible. I believe that the results are worthwhile, and it provides us with the means of evidence-based practice and the possibility of preventing many of the problems of bereavement and to treat those problems that do arise.